Hello everyone, welcome to my video channel. Today I am going to cover regarding shoulder impingement syndrome or painful arc syndrome. I am going to start with an introduction, etiologies of shoulder impingement syndrome, regarding Bigliani and Morrison classification of acromion, pathophysiology of shoulder impingement, Neer Classification of shoulder impingement, radiological investigation, including X-ray, ultrasound, and MRI, the treatment, whether conservative, including physiotherapy and corticosteroid injection, and surgical management. Lastly, regarding the differential diagnosis of shoulder impingement syndrome. The disclaimer is the same in all my videos. Thank you. Now let's begin. As an introduction, shoulder impingement syndrome is a painful condition of the upper extremity resulting from a structural narrowing of the subacromial space. It is primarily diagnosed by history and physical examination. The mainstay of treatment involves identification early before the onset of degenerative changes, physical therapy exercises to strengthen the shoulder girdle, and pharmacologic interventions to decrease inflammation. Basic clinical differentiation between the shoulder, external impingement, and internal impingement is defined by the rotator cuff as the anatomic boundary. Internal impingement due to a repetitive impingement in overhead throwers or manual laborers and constitutes articular sided rotator cuff pathology. Glenohumeral internal rotation deficit GIRD and superior labrum anterior posterior test SLAP. External impingement, also known as shoulder impingement, is described as a painful condition of the shoulder that results from inflammation, irritation, and degradation of the anatomic structures within the subacromial space. Shoulder impingement syndrome is considered to be a cluster of symptoms and anatomic characteristics. This picture shows the shoulder joint anatomy, including the bony soft tissue and tendons surrounding the shoulder joint. Okay? Its anatomic border defines the subacromial space. The acromion and coracoacromial ligament provide the anterior border. The acromyoclavicular AC joint acts as the superior border and the humeral head serves as the inferior border. The acromion shape, it has a role in the development of external or outlet-based impingement syndrome. Again, as illustrated, the shoulder joint anatomy. Bigliani and Morrison classified the shape of the acromion by its three most common morphologies. Class 1 is due to flat acromion. Class 2 is due to curved acromion. Class 3 is due to hook acromion. This figure illustrates the Bigliani classification of acromion undersurface with corresponding supraspinatus outlet view radiograph. During the actions of the shoulder abduction, forward flexion, and internal rotation, normal shoulder girdle movement results in narrowing of the subacromial space. This subacromial space, which is normally 1 to 1.5 cm in width, narrows with the superior migration of the humeral head, allowing it to approach the anterior inferior edge of the acromion. The symptom of pain associated with shoulder impingement result from this movement due to the humeral head applying a compressive force to either the rotator cuff, the subacromial besar, or both structures. This picture illustrates the painful arc ranging from 45 degree to 120 degree. For acromyohumeral joint arthritis, the pain elicited with the range of movement of the shoulder around 170 degree to 180 degree. Shoulder impingement syndrome can be described according to A. The location of the impingement, characterized as external or internal, and or B. Based on underlying cause of the impingement, referred to as primary or secondary impingement. For A, external or subacromial impingement, it results from a mechanical or physical encroachment of the soft tissue located within the subacromial space. Internal impingement results when the tendons of the rotator cuff encroach between the humeral head and glenoid rim. Internal impingement is most commonly associated with the supraspinatus and infraspinatus tendon. This picture illustrates an inflamed subacromial besar and rotator cuff tendinopathy with prominent acromion seen. For B, in the primary impingement, there is structural narrowing of the subacromial space. Example of primary shoulder impingement syndrome example include those attributable to abnormal acromion anatomy, such as hook class 3 acromion or swelling of the soft tissues. Secondary shoulder impingement syndrome is characterized by normal anatomy at rest and onset of impingement during the shoulder motion, likely secondary to rotator cuff weakness, permitting uncontrolled cranial translation of the humeral head. Weakness of the trapezius and serratus anterior muscle, limiting the external rotation and rise of the scapula with abduction of the upper extremity, further narrowing the subacromial space. Neer classification for shoulder impingement is divided into 3 categories or stages of severity. In stage 1, impingement primarily results from edema, hemorrhage, or both, and is classically seen with overuse type mechanism. Stage 2 is characterized by greater fibrosis and irreversible tendon changes. In stage 3, a rupture or tear of the tendon may result from chronic, long-standing fibrosis. This picture illustrates the stages of shoulder impingement that started from edema or inflammation to fibrosis or tendonitis, and the last stage is rupture or tear of the tendon. For evaluation of shoulder impingement, overall diagnosis sensitivity of the physical examination is as high as 90%. Imaging studies are often performed to confirm diagnosis and to rule out other pathologies. If decision to obtain radiograph is made, it should be obtained bilaterally to evaluate potential anatomic differences and rule out other pathologies such as calcific tendinitis or arthritic changes. Plain radiograph standard shoulder films include 2 views, the AP anterior posterior and lateral or scapula Y view. This X-ray of AP view right shoulder shows the presence of bony spur. The AP view of the shoulder can be used to determine the critical shoulder angle, CSA, which involves the extent of lateral coverage by the acromion and the inclination of the glenoid. At critical shoulder angle more than 35 degree, there is increased likelihood that rotator cuff is contributing to impingement syndrome. Acromyohumeral distance (AHD) can help to detect rotator cuff pathologies and defects. This X-ray of right shoulder shows the critical shoulder angle CSA. CSA is the angle formed from a line parallel to the glenoid where it crosses a line from the most inferior part of the glenoid and the most lateral edge of the inferior acromion. The acromyohumeral distance (AHD) is measured from the inferior edge of the acromion to the humeral head. The normal range is between 7 to 14 mm in male and 7 to 12 mm in women. A lower AHD acromyohumeral distance suggests rotator cuff pathology. The wide scapular view allows for the assessment of the humeral head on the glenoid. Plain radiograph featuring outlet view will best visualize and evaluate the shape of acromion. This X-ray of right shoulder shows acromyohumeral distance on the Rockwood view, marked as C, that was measured between a radiodense line on the inferior acromyocortex and a line to it tangent to the humeral head. Ultrasound is a bedside imaging option that enables assessment of the soft tissue contributing factors such as bursitis, tendinopathy, and/or tendon ruptures. MRI is recommended after 6 weeks of therapy without clinical improvement. MRI allows detailed evaluation of bony and soft tissue structures within the shoulder girdle. Treatment or management. The foundation of the management of shoulder impingement syndrome has been rehabilitative exercise programs with subsequent surgical intervention if indicated by underlying anatomy, pathology, or failure of response to physiotherapy. Without non-structural damage, non-operative therapies with controlled exercise program, NSAIDs, non-steroidal anti-inflammatory drugs, and subacromial injection are considered the treatment of choice for the first 3 to 6 months of treatment. Physiotherapy should consist of exercises that focus on rotator cuff strengthening, especially on supraspinatus and infraspinatus rotator cuff muscles, the trapezius and serratus anterior strengthening, and retraining exercises to minimize the scapular dyskinesia and other exercises to correct strength imbalance of the upper extremities. This illustration shows the example of rotator cuff injury exercises that include the scapular range of movement, the wand exercises, the tubing exercise for external rotation, isometric exercise. The combination of exercise with other conservative therapy leads to greater improvement in pain score compared to either treatment alone. Physiotherapy plus localized injection resulted in a maximized treatment effect compared to solitary localized injection. Regarding corticosteroid injection, commonly used is the posterior subacromial approach. A 1.5-inch 21 or 22 gauge needle with lidocaine and corticosteroid is commonly used. In this approach, first locates the posterior shoulder portal that is located 1 cm medial and inferior to the posterior corner of the acromion. While angling the needle in the direction of the underside of the acromion, the needle is advanced towards the acromion in an anterior superior direction. This picture illustrates the posterolateral soft for corticosteroid injection. For surgical intervention, arthroscopic subacromial decompression (ASD) consists of acromyoplasty at the anterolateral edge, vessel debridement and resection of the coracoacromial ligament. ASD, arthroscopic subacromial decompression, or other procedure recommended when a patient has a severe, persistent subacromial shoulder pain with functional impairments that have not improved despite conservative therapy. Finally, regarding differential diagnosis of shoulder impingement syndrome. This includes adhesive capsulitis, rotator cuff tear, acromyoclavicular joint arthritis, acromyoclavicular joint sprain, trapezius muscle spasm, bicep tendonitis, bicep tendon rupture, calcific tendonitis, glenohumeral arthritis, cervical radiculopathy, and thoracic outlet syndrome. I hope you have learned something from this video. See you in the next one. Take care and bye.